When we're talking about something as critical as breast cancer spreading to the bones, you'd hope our go-to imaging tools would give us a really clear picture.
Right. The best possible view.
But it turns out they can be surprisingly limited. Our expert today put it quite bluntly in his presentation, actually.
Oh.
Yeah, describing traditional CT and bone scans for this purpose as, and I'm quoting here, shitty scans and BS scans.
Wow. Okay. Strong words.
Strong words, definitely. But they immediately tell you we're talking about some significant shortcomings here.
It might sound quite direct, but I suspect it comes from, seeing firsthand how these limitations can really impact the care of women with metastatic breast cancer. It's actually fascinating how a more advanced imaging technique could potentially offer so much more clarity.
Absolutely. And that's exactly what we're digging into today. We're exploring the power of whole body MRI, or WB-MRI, as a potentially better way to understand and manage breast cancer, especially when it spreads or metastasizes to the bones. For you, the learner, think of this maybe as a shortcut to a more complete understanding, potentially filled with those aha moments as we kind of reveal why the older methods aren't always up to the task and, what this newer approach brings to the table.
Yeah, and if we connect this to the bigger picture, like navigating a complex disease like metastatic breast cancer, the ability to get comprehensive information without completely overwhelming the patient is just so important.
Definitely.
This isn't about making things more complicated. It's really about bringing much needed clarity,
Guiding us through this is Professor Pinani, a consultant radiologist whose presentation is the foundation for our discussion today. Okay. And just for full transparency, it's worth noting that Prof. Pinani has received research support from Siemens Healthineers. We should also be aware that our discussion today might touch on, off-label uses of certain drugs, equipment, and software. Now, for our listeners, whether you're deeply experienced in radiology or focused on oncology, our learning objectives for this session are really quite targeted.
Yes, exactly. By the end of this discussion, you should have a much clearer understanding of the limitations of CT and bone scans in detecting bone metastases and, crucially, assessing treatment response. We'll also cover the standard WB-MRI protocols and the key clinical situations where it's most valuable, particularly when evaluating bone involvement. And we'll also be highlighting how the quantitative aspects of WB-MRI can contribute to a more personalized approach, precision oncology for breast cancer patients with bone metastases.
And finally, to keep a balanced perspective, we will also discuss the current challenges and the questions that still need answering about the overall effectiveness of WB-MRI in these clinical scenarios.
Okay, let's get into it. First up, looking at the limitations of CT. We have a case here, a 57-year-old woman with HER2 positive metastatic breast cancer. She'd had initial dose of Taxol and was then on adjuvant Herceptin, pertuzumab, and Zometa. Reviewing her CT scans over about 7 months, the reports consistently just read stable.
Right, and this case really highlights a fundamental challenge with CT in the context of bone metastasis. While the CT images showed no significant changes in the bone structure itself, that doesn't necessarily tell us what's happening within the bone marrow at a cellular level. This is a critical teaching point. CT primarily visualizes changes in the bone matrix, and early metastatic disease within the marrow may be invisible. Because when we think about the biology of bone metastasis in those very early stages, tumor cells can actually colonize the bone marrow without yet affecting the surrounding bony architecture.
That's right. These tumor cells can remain dormant in stem cell niches, not yet triggering the osteoblastic or osteolytic activity, the bone building or bone destruction that CT and bone scans primarily detect. They haven't yet initiated that vicious expansion, as it's called, that leads to visible lesions on those traditional imaging modalities.
Right.
The key insight here is that traditional imaging misses this early biologically active phase.
So CT essentially only becomes a useful tool once the tumor starts to actively interact with the mineralized bone, either by forming new bone or by breaking down existing bone.
Precisely. But importantly, even before these structural changes occur, other techniques like FDG-PET and diffusion-weighted imaging or DWI on MRI can potentially detect disease earlier. They do this by looking at increased metabolic activity within the marrow space or by identifying changes in cellularity and water movement that are characteristic of tumor infiltration.
Which brings us back to the recognized shortcomings of CT in assessing bone disease. It's not just about potentially missing those very early stages, is it? Even when lesions are visible on CT, the standard RECIST criteria Response evaluation criteria in solid tumors, which often rely on measuring lesion size, just don't work particularly well for bone.
No, they don't. That's because bone metastases are frequently deemed non-measurable according to those size-based criteria. Furthermore, it can be really challenging to determine true progression on CT. For example, if there's diffuse marrow infiltration without a significant change in the calcified bone, or if tumor cells are infiltrating within bone that has already been scarred by previous radiation therapy, this is a critical limitation for a response assessment.
And we also have that difficulty in distinguishing between sclerotic progression, where the bone becomes denser, indicating the cancer is worsening, and a sclerotic response to treatment, where the bone is also becoming denser as it heals.
Exactly.
CT, focusing as it does on the bone matrix, often struggles to differentiate these crucial scenarios.
Precisely. And a significant point for clinicians is that CT primarily provides progression criteria. It doesn't really offer direct assessments of treatment benefit in bone disease. We often see clinical scenarios where patients are clearly deteriorating, perhaps symptomatically, but their CT scans haven't shown significant enough changes to meet formal progression criteria. And that brings us to bone scans, which, as Professor Pratani humorously pointed out, have their own set of rather challenging rules. A key issue here is the inherent delay in confirming progression. There's this thing called the 2+2 rule.
Okay, what's that?
It means you need to see 2 new lesions on an initial scan and then confirm them with 2 more new lesions on a follow-up scan to officially call it progression.
Wait, you have to wait for more lesions to show up?
Yes, and that delay can mean valuable time is lost before considering a change in treatment. Professor Pratani felt that delay seems, well, almost unethical when you're dealing with an aggressive disease.
Waiting for the cancer to visibly spread more before acting. That sounds incredibly frustrating for everyone involved, especially the patient.
It is. And there are other limitations, too. Bone scans can struggle to distinguish between true progression and something called pseudo-progression.
Pseudo-progression.
Yeah, it's like a temporary flare-up or increase in activity on the scan that can actually happen when a treatment is working. The body's healing response can sometimes look like worsening disease initially.
Okay, tricky.
Very tricky. And they also can't accurately assess diffuse disease that happens in what are called superscan patients, where basically the entire skeleton shows increased uptake.
So you can't track individual spots.
Right. You can't track new lesions easily. So these patients often get excluded from clinical trials. And importantly, clinical progression, the patient feeling worse or their tumor markers rising, that can happen frequently, even when the bone scans show no change at all.
So when we put it all together, it seems that both CT and bone scans, because they're essentially indirect indicators of what's happening within the bone marrow, they significantly limit our ability to accurately detect, characterize, and effectively assess the response of bone disease to treatment.
That's precisely the core problem. These limitations can have significant and direct impacts on the therapy choices we make for our patients. False positives or false negatives can inadvertently lead us down the wrong treatment path, potentially causing unnecessary harm or delaying effective therapies.
And the often resulting delay in identifying patients who are not benefiting from their current treatment regimen that can really impede their access to alternative, potentially more effective options. It potentially increases healthcare costs and treatment-related toxicities without any real clinical benefit, too.
Exactly. We need imaging modalities that can provide a more direct and sensitive assessment of the true extent of the disease, whether it's minimal, more widespread, or somewhere in between. And crucially, help us identify much earlier on which patients are not responding to the treatment they are currently receiving.
Okay, so how does whole-body MRI aim to overcome these well-recognized hurdles? What does the standard protocol for WB-MRI typically look like when we're assessing for bone metastases?
Right. WB-MRI offers a more direct and comprehensive look into the bone marrow using a combination of both morphological and functional imaging sequences. There are generally 2 main types of protocols: a core protocol and a more comprehensive or extended protocol. Both protocols typically begin with sagittal T1 weighted and ester sequences of the entire spine. The SD sequence short tau inversion recovery is particularly valuable because it's highly sensitive to the presence of fluid and inflammation within the bone marrow, which can be early indicators of metastatic involvement.
And then what are the key differences that distinguish the core protocol from the more extended one?
Okay, the core protocol generally includes a whole-body T1 weighted Discssion sequence. This allows for the separate visualization of fat and water within the tissues, and it's typically acquired either in the axial or coronal plane. This is followed by axial diffusion weighted imaging, or DWI, covering the body from the skull base down to the mid-thighs using at least 2 different B values. These B values are crucial as they help us assess the movement of water molecules. Restricted water diffusion is a hallmark of areas with high cellularity, like tumors. Axial T2 weighted sequences without fat suppression are often included as an option in the core protocol.
So the extended protocol then builds upon this foundation of sequences.
Yes. The comprehensive or extended protocol includes all of the imaging sequences from the core protocol and importantly adds both axial and coronal T1 weighted Discssion imaging. This provides more complete anatomical coverage and a better assessment of fat infiltration throughout the body. It also typically uses at least 2 and often 3 different B values for the DWI acquisition. This allows for more sophisticated analysis of water diffusion and improved tissue characterization. Additionally, axial T2 weighted sequences are a standard component of the extended protocol. Furthermore, the extended protocol offers the flexibility to include regional assessments like more detailed imaging of specific areas like the brain or lungs, and the use of intravenous contrast enhancement if clinically indicated. These protocols are largely in alignment with the MET-ARADS guidelines, which provide valuable recommendations for standardized imaging and reporting.
Now, to really understand how these protocols work in practice, could you maybe walk us through a specific example of an extended WB-MRI protocol, say one that might be used for baseline surveillance?
Certainly. Let's consider a hypothetical case. A 48-year-old woman recently diagnosed with early-stage invasive ductal breast cancer undergoing baseline surveillance. On a Siemens 1.5 Tesla MRI scanner, a comprehensive extended protocol might include the following. We'd start with sagittal stir and T1 weighted sequences of the entire spine, each taking maybe 2 to 2.5 minutes. Next, we might include an axial flare sequence of the brain to screen for any unexpected intracranial findings. For the lungs, a rapid breath hold PD vibe sequence can be acquired. Then we move to the axial sequences covering the entire body from neck down to upper thighs. This would typically include a T2 weighted haste sequence, followed by the T1 weighted fat fraction vibe sequence, which generates various reconstructions in phase, post-phase, fat-only, water-only images. Crucially, we'd acquire the DWI sequences with at least 2, often 3, B values, and from this data, generate the corresponding ADC or apparent diffusion coefficient maps. Finally, we might acquire coronal SDR and coronal T1 weighted fat fraction VBE images, and often a Bienen maximum intensity projection or MIK image derived from the high B value DWI data. The total imaging time for such an extended protocol, not including table movements and adjustments, is often in the range of 40 to 45 minutes. This detailed example gives you a sense of its comprehensive nature.
You've mentioned diffusion-weighted imaging, DWI, several times now. Sounds like it's a really critical component of WB-MRI for detecting metastases. Can you explain why DWI is so important here?
DWI is truly a cornerstone of WB-MRI for metastasis detection. Why? Because it's exceptionally sensitive to the cellularity and viability of tissues. Tumor cells are typically very densely packed, right? This restricts the random movement of water molecules within the tissue.
Okay.
This restricted diffusion shows up as areas of high signal intensity on specific DWI sequences and correspondingly as low signal intensity on the calculated ADC maps. This is a key teaching point. Areas of restricted diffusion are highly suggestive of malignancy.
So by looking at these DWI images and ADC maps, we can potentially differentiate between tissues that are benign and those that are more likely to be malignant.
Exactly. And the clinical applications of DWI and WB-MRI are quite broad. It's not just valuable for initially detecting lesions, it also plays a significant role in characterizing those lesions and in monitoring how they respond to therapies over time. There are several key advantages to incorporating DWI. The technique is becoming increasingly standardized thanks to guidelines like MET-RADS. It's widely available on most modern MRI scanners. It's relatively quick to perform, interpret, and repeat. And crucially, it involves absolutely no ionizing radiation and no need for radioactive isotopes.
And you also mentioned that DWI provides quantitative information.
Yes, that's a significant advantage. From the DWI data, we can derive important quantitative parameters, things like the overall volume of tumor burden, the actual ADC value within a lesion, and even the fat fraction within the bone marrow. Furthermore, DWI allows us to assess the heterogeneity of the disease, both spatially looking at different sites in the same patient and temporally observing how these parameters change over time with treatment. This ability to quantify changes is crucial for effective response monitoring.
Now, I noticed something in the presentation about DLR-DWI. What's the primary advantage of using this technique in WB-MRI?
Ah, yes. DLR-DWI stands for Deep Learning Reconstructed Diffusion Weighted Imaging. Basically, recent advancements in AI and machine learning applied to image reconstruction algorithms. They've led to techniques that can significantly reduce the acquisition times for DWI sequences. And they do this while simultaneously maintaining, and sometimes even improving, the overall image quality. For example, the presentation highlighted a case of a woman with bone and lung metastases where conventional DWI took about 14 minutes. Using DLR-DWI, comparable diagnostic image quality was achieved in just over 6 minutes.
Wow, that's a big difference.
It is. This substantial reduction in scan time can lead to improved patient comfort, better compliance, and increased efficiency in the MRI department.
That sounds very promising, particularly given that the total imaging time for a comprehensive WB-MRI can sometimes be a factor. Are there any potential drawbacks or limitations to be aware of when using AI in image reconstruction like this?
Well, it's important to acknowledge that there is a potential risk for AI algorithms to introduce subtle artifacts into the reconstructed images. However, the general consensus is that the significant benefits of reduced scan time, coupled with preserving comparable diagnostic information, often outweigh this potential risk in many clinical settings, especially with potentially lengthy WB-MRI exams. Radiologists simply need to be aware of this possibility and interpret the images within the context of the entire clinical picture and other findings.
Now, going back to the imaging protocols themselves, could you give us a more detailed breakdown of the key differences between the core and the extended protocols, particularly focusing on the types of image reconstructions that are typically generated?
Certainly. So, as we said, both include the sagittal SDR and T1 of the spine. The T1 Discssion in the core protocol can be axial or coronal, whereas the extended protocol includes both planes, giving a more thorough assessment of fatty infiltration. The DWI in the core uses at least 2 B values primarily focused on detection. In contrast, the extended protocol often incorporates a 3rd B value, which can refine the ADC calculation and aid characterization. Crucially, the extended protocol includes specific DWI reconstructions not usually in the core. These include coronal multiplanar reformations of the high B-value DWI images and 3-dimensional maximum intensity projection 3D MIP reconstructions of the highest B-value DWI data.
Okay, those 3D MIPs.
Yes, they're often displayed using an inverted grayscale, which can make them look visually similar to P images. They can be particularly helpful for quickly assessing the overall burden of disease throughout the body. Additionally, axial T2 weighted images are typically optional in the core but standard in the extended protocol. And finally, the extended protocol allows for those important regional assessments, specialized sequences, and image fusions if needed.
You mentioned image fusion. Can you give us a specific example of when fusing WB-MRI images with images from another modality might be particularly helpful in managing bone metastases?
Absolutely. Consider a case presented involving a patient with a history of both breast and ovarian cancer, where there was a question about a lesion in the T12 vertebra. A specialized MRI sequence called PDWIVBE can be used to create a pseudo-CT-like appearance of the bone matrix on the MRI. When the pseudo-CT image is then digitally fused with the high B900 DWI images from the WB-MRI, it can be extremely helpful in precisely identifying areas of active soft tissue disease that might be present around the vertebral body.
I see. For targeting.
Exactly. This precise localization is absolutely critical for effectively guiding subsequent biopsies. In the specific example shown, an initial biopsy likely targeting the sclerotic, inactive part of the lesion unfortunately came back negative. However, the fused imaging clearly highlighted the adjacent active soft tissue component, allowing for a much more targeted and ultimately successful subsequent biopsy.
That really underscores the benefit of combining detailed anatomy from MRI with functional information from DWI and maybe other modalities too. And speaking of biopsies, the presentation also touched on using quantitative multiparametric bone MRI to help guide these procedures. What's the key clinical takeaway from that?
The key clinical takeaway there is that by combining specific quantitative parameters from multiparametric bone MRI, we can significantly improve the accuracy of CT-guided biopsies of suspected bone metastases. Specifically, the research suggests that identifying areas with high signal on high B-value DWI, low ADC values typically below 1,100 meters, and a low fat fraction proved 20% on fat fraction maps. These things can reliably identify active bone metastases. They do so with high specificity, around 80% in some studies, and a very good positive predictive value, maybe as high as 93%, for getting a tumor-positive biopsy core that's suitable for downstream molecular analysis like NGS.
Yay.
This multi-parametric approach lets us target the most metabolically active parts of the disease. increasing the likelihood of a successful diagnostic biopsy and providing crucial tissue for personalized treatment planning.
That sounds incredibly valuable for advancing precision oncology. However, the presentation also included a note of caution, pointing out that not all bone deposits will show this characteristic high signal on DWI. Can you elaborate, particularly regarding lobular breast cancer?
Yes, that's a really crucial point for listeners to understand. While a high B900 signal on DWI is generally a strong indicator of active metastatic disease due to increased cellularity, it's important to remember that not all bone metastases will present this way. In certain subtypes, like invasive lobular breast cancer, bone metastases can often be predominantly sclerotic. This dense sclerosis can sometimes result in lower signal intensity on DWI compared to more cellular metastases in other subtypes.
Okay, so what's helpful then?
In these situations, the T1-weighted fat fraction imaging can be exceptionally useful for assessing the extent of bone marrow replacement by tumor, even if the DWI findings are less pronounced. Interestingly, those pseudo-CT images we discussed earlier, they can often closely resemble actual CT scans in depicting this sclerosis. The presentation even showed a case where liver metastases from lobular cancer were clearly visible on B900 DWI, but weren't readily apparent on the soft tissue windows of the conventional CT scan, a recognized characteristic in this subtype. Furthermore, a study was mentioned which indicated that adding WB-MRI to standard protocols led to more frequent treatment changes in patients with lobular versus ductal breast cancer, highlighting its potential impact in this specific subgroup.
So it appears WB-MRI offers some really unique advantages, particularly in the often challenging management of bone metastases from lobular breast cancer. Let's transition now to discussing some of the key clinical indications where WB-MRI is proving most valuable. Characterization of equivocal findings on conventional CT or bone scans was highlighted. Can you give us a practical example?
Certainly. Consider a scenario. A 38-year-old woman diagnosed with high-risk locally advanced breast cancer. Initial staging with bone scan and CT chest-abdomen pelvis comes back. Somewhat discordant. The bone scan shows a few areas suggestive of possible METs, but the corresponding CT areas don't clearly confirm bony metastases.
Okay, that happens.
It does. In such a situation where traditional imaging provides conflicting or inconclusive results, WB-MRI can be invaluable. The presentation illustrated this with a case where the WB-MRI revealed extensive bone metastases, characteristic high B900 signal, low ADC, low fat fraction in the affected marrow. These findings on WB-MRI effectively resolve the ambiguity, providing a much clearer, more accurate picture of the true extent of the patient's metastatic burden.
That's a really compelling example of WB-MRI acting as a problem solver. Are there any potential pitfalls, though? Benign conditions that might mimic METs?
Yes, it's essential to remember that while DWI is highly sensitive to cellularity, its specificity for cancer isn't absolute. We can occasionally encounter false positives. The presentation highlighted a relevant case, a 46-year-old woman with DCIS. Both an FDG-PT and the B900 DWI images showed findings initially suggestive of bone disease. However, careful evaluation of the mediastinum on the PTT scan revealed findings more consistent with sarcoidosis, which was later confirmed. This case is an important reminder for careful, comprehensive interpretation of WB-MRI, always within the context of the patient's full clinical history and other imaging.
Another interesting indication mentioned was using WB-MRI in patients experiencing aromatase inhibitor-related arthralgia. How can WB-MRI help there?
Right. Aromatase inhibitors are very effective hormonal therapy, but a significant side effect for some women is significant joint pain or arthralgia. This pain can understandably raise concerns for both patients and clinicians about possible underlying bone metastases. In this context, WB-MRI can play a valuable role in reassuring patients by demonstrating the absence of active metastatic disease in the bone marrow or joints. The presentation included a case. A 55-year-old woman, history of breast cancer, developed widespread arthralgia after starting exemestane. A subsequent WB-MRI revealed radiation fibrosis in the chest wall, also seen on previous scans, but crucially, showed no evidence of active metastatic disease explaining her arthralgia. This negative finding on WB-MRI can provide significant reassurance and help avoid unnecessary anxiety and further tests.
That's a valuable application focusing on quality of life. What about its role in inherited cancer predisposition syndromes?
The WB-MRIs become increasingly important in the surveillance of individuals with inherited cancer predisposition syndromes, like Life-for-Many syndrome, where there is a significantly increased lifetime risk of various cancers. Here, the goal of regular surveillance imaging is early detection of any new primary cancers or metastatic disease at an early, potentially more treatable stage. The presentation highlighted a compelling case. A 47-year-old woman, known TP53 mutation carrier, linked to Life-RMNE, undergoing routine whole-body MRI screening. This exam unexpectedly detected a previously unknown enlarged axillary lymph node, prompting further investigation and timely intervention. Importantly, research studies have actually demonstrated a survival benefit for individuals with Life-RMNE who undergo regular surveillance, including WB-MRI. Plus, the fact that MRI doesn't involve ionizing radiation makes it particularly attractive for this population needing frequent long-term surveillance.
Let's circle back to invasive lobular breast cancer again. We touched on different patterns of bone involvement. Could you elaborate on some specific patterns that might be challenging for traditional imaging, but clearer on WB-MRI?
Yes, invasive lobular carcinoma has a reputation for presenting in unusual, often subtle ways in bone. One common pattern is diffuse infiltration of the bone marrow without causing significant changes in the bone matrix itself. This type of involvement can be very hard to detect with CT and bone scans.
Okay.
We can also see a characteristic ring sign on fluid-sensitive MRI sequences like T2 or STIR, a central area of sclerosis surrounded by a rim of tumor. Other patterns include a salt and pepper appearance from mixed sclerotic and olytic changes, diffuse osteoblastic patterns, or less commonly dominant osteolytic lesions. The presentation revisited that 38-year-old LABC case, showing how WB-MRI revealed much more extensive marrow involvement than the CT initially suggested. It also showed a 61-year-old woman with metastatic lobular cancer showing the classic ring sign on a star. These varied, often subtle patterns really underscore the added value of WB-MRI for a comprehensive assessment in lobular breast cancer.
And how does WB-MRI compare to FDG-PB for monitoring treatment response, specifically for lobular versus ductal cancers in bone?
That's an important distinction. Bone mets from lobular cancer often tend to be more densely sclerotic and might exhibit lower glucose metabolism compared to ductal mets. This lower metabolic activity can sometimes make them less avid or less bright on FDG-PE scans.
Right.
However, these lobular metastases often maintain relatively high cellularity, which makes them more readily detectable and allows effective monitoring using DWI on WB-MRI. In contrast, ductal breast cancer bone mets can be more mixed lytic and sclerotic components and frequently show higher FDG uptake, making FDG-P useful there. So while FDG-P can be valuable for monitoring ductal bone mets, WB-MRI with DWI is often preferred for assessing response in bone mets from lobular breast cancer.
Another unique and important scenario introduced is pregnancy-associated breast cancer, PABC. What's the main reason for using WB-MRI in these cases?
PBC, pregnancy-associated breast cancer, is relatively rare but often aggressive, diagnosed during pregnancy or postpartum. These cancers tend to be higher grade, often hormone receptor negative. Given the critical need to minimize any radiation exposure to the developing fetus, non-ionizing methods like WB-MRI become particularly valuable for both initial staging and monitoring response. The presentation included a very informative case, a 34-year-old woman diagnosed with triple-negative MBC during pregnancy. She underwent initial staging and follow-up with WB-MRI throughout pregnancy and postpartum. This case nicely illustrated WB-MRI's effectiveness for assessing disease extent initially and monitoring response to chemo, all without exposing the fetus to ionizing radiation.
Moving beyond these specific scenarios, are there other high-risk clinical presentations in breast cancer where WB-MRI might offer particular advantages over traditional imaging?
Yes, absolutely. Several other high-risk situations benefit. These include patients with inoperable locally advanced breast cancer, inflammatory breast cancer, cases with clinical suspicion of extranodal spread, patients experiencing an early relapse after primary treatment, or individuals with a rapid, significant rise in serum tumor markers. The presentation illustrated this with a case, a 52-year-old woman with recurrent lobular breast cancer. WB-MRI using DWI-infused imaging revealed a much more extensive metastatic burden than might have been suspected from traditional imaging alone.
What about in the specific context of oligometastatic disease, where there's only a limited number of metastatic sites? How does WB-MRI fit in there?
In oligometastatic disease, accurate identification and characterization of all metastatic sites is crucial for treatment planning, especially when considering metastasis-directed therapies like surgery or stereotactic radiotherapy. Whole-body MRI can play a key role here by providing a comprehensive assessment of the entire body, helping ensure all sites are accurately identified and localized. The presentation included a case, a 63-year-old woman with IDC who presented with what seemed like a solitary bone met. This was treated with CyberKnife stereotactic radiotherapy. Follow-up WB-MRI showed a positive treatment response, evidenced by a significant increase in the ADC value within the treated area, even though there were only minimal changes in its overall morphology on conventional sequences.
That really emphasizes the added value of those quantitative parameters again, particularly for assessing response.
Precisely. It indicates successful cell kill and treatment effect, even when the lesion looks morphologically stable. It provides functional information about response.
And it leads nicely into response monitoring overall. How is WB-MRI used more broadly to see how bone mets are responding?
It's increasingly used, especially, as we said, in bone-only disease or bone, liver, or multi-organ disease with chest CT. We look for changes in lesion size and morphology, yes, but crucially also those functional changes on DWI and ADC. An increase in ADC is often a good sign. We also assess overall disease burden and look for any new lesions.
You showed that complex case treated with a CDK46 inhibitor. The B900 signal went down, fat came back in the marrow, good signs, but the pseudo-CT showed sclerosis. How do you interpret that kind of mixed picture?
That's a great example of the challenges. Decreased DWI signal, return of fat on T1 usually indicate response. But new or increased sclerosis on the pseudo-CT, could that be response with bone repair? Or could it be sclerotic progression? Or even pseudo-progression if it's early.
So how do you weigh those findings?
You have to integrate everything. Look at all the WB-MRI sequences, look at the trend over time with serial scans if available, and correlate heavily with the patient's clinical picture and tumor markers. It's rarely just one finding in isolation.
And then there was the case where T1 and STR were equivocal, but the DWI clearly showed response.
Yes. That highlighted how DWI can sometimes provide much clearer evidence of response than standard morphological sequences. The reduction in DWI signal, maybe resolution of nodes, can be unambiguous even when T1 STR changes are subtle. It reflects the change in cellularity.
And you mentioned ADC histogram analysis can back this up quantitatively.
Exactly. Analyzing the distribution of all the ADC values within the metastatic bone disease can show a shift towards higher values after effective treatment. It gives an objective measure confirming the visual impression of response seen on the DWI images.
Okay, so summarizing response assessment. It's about combining morphological changes, size, soft tissue components, return of fat with functional changes, primarily increased ADC derived from DWI, and you showed a model of different response patterns.
Right, understanding those patterns is key. True progression, more tumor, stable ADC usually. Response with cell kill, less tumor, more water, so ADC goes up, DWI signal drops. And response with repair, fibrosis, sclerosis, fat return, signal drops, but maybe ADC doesn't increase much. Recognizing these helps avoid misinterpreting the images.
This all ties into the MET-RADS response assessment categories, RAC. Can you briefly explain that system for those unfamiliar?
Sure. MET-RADS RAC is a standardized reporting system, mainly for WB-MRI. It uses a 5-point scale. RAC1 means likely response or stable disease with good features. RAC5 means definite progression. RAC2, 3, 4, intermediate categories.
And the benefit is consistency.
Exactly. It provides a common language for radiologists and oncologists to describe the likelihood of response or progression based on the imaging findings. Makes communication clearer and hopefully decision-making better. Each RAC score has a clinical equivalent, like complete response, partial response, stable, possible progression, definite progression.
And tracking the RAC score over time can show the treatment trajectory.
Yes, you can follow the RAC score on serial scans. Seeing a patient maintain RAC 1 or 2 is reassuring. Seeing the score climb towards 4 or 5 suggests treatment resistance is developing. And importantly, early changes in these RAC scores have been shown to have prognostic value. There are studies indicating that patients who achieve a maximum RAC score of 1 or 2, meaning a good response early in their treatment, tend to have significantly better overall survival down the line.
Wow, so it can predict outcomes.
It appears to be a powerful early indicator, yeah, which could be really valuable for guiding treatment decisions, maybe escalating therapy if the RAC score isn't improving, or continuing if it is.
The findings of the RESPECT study were also highlighted. What were the most significant conclusions from that research regarding WB-MRI's utility in evaluating response in bone-only metastatic breast cancer?
The RESPECT study directly compared WB-MRI, conventional CT, and bone scans for evaluating response in women with bone-only metastatic breast cancer starting new systemic therapy. It yielded some truly significant findings, perhaps most striking. Two-thirds of all instances of disease progression were detected by WB-MRI alone, meaning they weren't identified by either CT or bone scan.
Wow.
Furthermore, no patient in the study showed progression based on CT imaging alone. And surprisingly, bone scans failed to detect progression in a full 50% of women who were actually progressing in their bone mets. These findings strongly underscore the limitations of traditional imaging here and highlight WB-MRI's potential to detect progression earlier and more accurately.
Those are really quite impactful findings. And what about the real-world clinical impact of adding WB-MRI to standard CT imaging in outpatient clinics?
A study specifically examined that. It found that adding WB-MRI led to detecting more disease in a remarkable 53% of patients. It also resulted in a change in the assigned response category in nearly 28% of cases, and a significant 35% of all therapy changes implemented were solely attributed to the WB-MRI findings. This included detecting progression in almost 19% of cases that had been classified as stable based on CT alone. This data strongly suggests WB-MRI provides clinically relevant, actionable information that directly influences treatment decisions.
So the clinical utility seems well supported. But what about the patient's perspective? How do patients generally feel about WB-MRI compared to, say, CT scans?
The RESPECT study looked at patient acceptability too. While patients generally indicated willingness to repeat both CT and WB-MRI, there was a noted preference for CT, mainly due to its shorter scan time. Some patients also reported slightly higher levels of concern or helplessness with the MRI exam. However, overall satisfaction was high with both, and the fact that repeat scan rates are generally quite high in breast cancer surveillance suggests WB-MRI is, for the most part, an acceptable modality in this setting.
It's certainly important to take the patient experience into consideration as we think about broader adoption. Now, as we begin to wrap up our deep dive, what are some of the ongoing challenges and unanswered questions regarding widespread implementation of WB-MRI?
Despite the compelling data we've discussed, several important challenges remain. We currently lack definitive, large-scale evidence showing an improvement in overall survival directly attributable to treatment decisions guided by WB-MRI. There's also ongoing uncertainty about the natural history and long-term prognosis of METs detected by WB-MRI but not visible on conventional CT. Are they biologically distinct or just earlier detection? We need more research.
Right.
The high sensitivity of WB-MRI also raises potential concerns about overtreating lesions that might not be clinically significant. And we need to be mindful of biases like lead time and length time bias, which can influence outcome interpretation.
Those are all really important points. So in concluding our discussion today, what's the overall key message regarding WB-MRI's potential role in advancing precision oncology for patients with metastatic breast cancer to the bone?
The overarching message is that next-generation imaging, certainly including WB-MRI, holds significant promise in potentially replacing traditional, arguably less effective methods like CT and bone scans for comprehensive assessment of bone mets in breast cancer. WB-MRI has the unique ability to positively influence our diagnostic thinking on treatment response by directly demonstrating treatment success rather than just the absence of progression. This can lead to more meaningful, beneficial treatment adaptations through MDT discussions. It's particularly valuable in specific scenarios: lobular breast cancer, Li-Fraumeni syndrome, pregnancy-associated breast cancer, and for monitoring bone and liver disease. While important challenges remain, the growing evidence strongly suggests WB-MRI is a powerful, increasingly valuable tool, moving us closer to a more precise, personalized approach for these patients.
It certainly sounds like a really significant step forward in how we can better care for our patients. For those of you interested in delving even deeper and gaining more practical knowledge, the presentation mentioned the ICIS Masterclass in Oncological Whole Body MRI.
Yes, that ICS Masterclass represents an excellent opportunity for both radiologists and oncologists to acquire in-depth knowledge and gain valuable practical experience in performing and interpreting whole-body MRI in oncology.
So just to reiterate the key takeaways from our discussion today, it really seems WB-MRI offers tremendous potential to significantly enhance how we manage breast cancer patients with bone disease by effectively overcoming many limitations of traditional imaging.
Absolutely. A thorough understanding of the WB-MRI protocols, recognizing its utility across various challenging scenarios, detection, staging, planning, response monitoring, and appreciating the added value of quantitative parameters like ADC and fat fraction. These are all key for successfully integrating this powerful technology into routine practice.
And while we acknowledge ongoing challenges and the need for more robust research on survival outcomes, the compelling evidence reviewed today strongly indicates WB-MRI can facilitate more informed treatment decisions and potentially lead to improved patient outcomes.
Indeed. It really encourages us to think differently, more comprehensively, about how we approach assessment and management of metastatic breast cancer to bone.
On that thought, it brings to mind a quote often attributed to Einstein. "We cannot solve our problems with the same thinking we used when we created them." End quote. Perhaps the increasing adoption of advanced imaging like WB-MRI represents that necessary new way of thinking to tackle the persistent challenges in managing metastatic breast cancer to bone. For those interested in exploring further, we highly encourage you to follow Professor Patani on Twitter at Prof. Patani and check out his YouTube channel for more educational resources. Thank you for joining us for this in-depth exploration.